morning. This is Nebulized Medication Administration for the EMT Basic. This is the North Dakota EMS authorization course for the enhanced skills for the EMT Basic. My name is Christopher South, and I am the Education Director here at Metro Area Ambulance and Bismarck Air Medical. So our objectives, we're going to review the respiratory anatomy. We're going to look at respiratory emergencies that may cause bronchial constriction. We're going to look at bronchial constriction and bronchospasm. We're going to recognize the need for nebulized medication. We're going to describe the class, indications, contraindications, and side effects of nebulized medications. We're going to talk about how to administer nebulized medications and how to use a handheld nebulizer. So respiratory anatomy, okay? So we have the upper airway is going to consists of the oral cavity, which includes the pharynx, the nasal cavity. The lower airway is going to consist of the larynx, the trachea, the bronchi, which divide down to the bronchial, and then eventually down into the alveoli. All right. Remember that the upper airway is going to be split right from the larynx all the way up to the nose, and the lower airway is from the larynx all the way down. Okay. So we're going to talk quite a bit about how these function. But one of the main things that we're going to be really looking at is lower airway. The lower airway, especially which is going to be past the trachea, going into the bronchi, the bronchioles, and especially down into the alveoli. And we're going to be really talking about the bronchioles and the alveoli quite a bit here in just a minute. So bronchial constriction, we just talked about the bronchi. Definition of bronchoconstriction is the constriction of the smooth muscles of the bronchi and the bronchioles. May be caused by a disease process, irritation, or other trigger resulting in a narrowing of the airway passage or a complete closure that may ultimately lead to hypoxia and death. A bronchial spasm, okay, is a spasm or constriction of those smooth muscles of the bronchi and bronchioles that leads to narrowing or complete closure of those airway passages. May be caused again by a disease process or external factors such as irritants that can cause a narrowing of the airway passage. So some of the most common causes of the bronchial constriction and bronchospasm is going to be chronic obstructive pulmonary disease, or COPD. And COPD is going to consist of chronic bronchitis and emphysema, asthma, pulmonary edema, pneumonia, and toxic inhalation. And this can also, toxic inhalation can also be caused by inhaling certain gases, things in a fire state, that kind of stuff. So COPD is a respiratory disease that causes obstruction to airflow in the lungs. And again, this is most typically caused by emphysema and chronic bronchitis. One of the major contributing factors to the causes of COPD, of course, is going to be cigarette smoking. Asthma is characterized by an increased sensitivity of the lower airway to irritants that cause diffuse, reversible narrowing of the bronchioles. So really, asthma, if we think about it, asthma is really an airway obstruction, and lower airway obstruction. It's actually causing an obstruction of the airway. It makes it very difficult for these patients to be able to breathe. And we see a lot of calls for asthmatics, all right? So we're going to get really into a couple of these things here as we go along with some of our airway problems. Pulmonary edema occurs when an excessive amount of fluid collects in the space between the alveoli and the capillaries. We can have the cardiac complaints or the cardiac causes of pulmonary edema is typically going to be associated with heart failure. All right. There's also some non-cardiac issues as well. Pneumonia is an acute infectious disease caused by viruses, bacteria, or even fungus that affects the lower respiratory tract and causes lung inflammation and fluid or pus-filled alveoli. One of the easy things that you can remember as we're going back through this very quickly is what some of these breath sounds that we may see in these patients. So with Chronic obstructive pulmonary disease, we're typically going to have wheezing if they're having difficulty breathing, they're experiencing some dyspnea, they're also having some exacerbation with their disease. We're typically going to hear wheezing, but we can also hear rhonchi as well, or those crackles. Asthma is typically going to be either a very narrowing or very difficult to hear, or we're going to have wheezes associated with it. Pulmonary edema is going to be, most of the time we're going to have those wet lung sounds known as rales. And pneumonia is going to be mostly associated, we can hear some wheezes in all of these different lung diseases, but with pneumonia we typically hear crackles. So signs and symptoms for patients that are experiencing some dyspnea, which is shortness of breath. They can have restlessness and anxiety. And the reason they have restlessness and anxiety is, think about when maybe you dove off pretty deep in the water and you almost ran out of breath getting back up to the surface. Think about that anxiety of trying to get back up to the top because you're out of breath. Increased or irregular heart rate, increased breathing rate, also known as tachypnea, pale or cyanotic skin, abnormal airway sounds, diminished ability or inability to speak, all right? Retractions, which is actually where we can see that's going to be accessory muscle use, coughing, tripod position, this is where they're holding themselves up trying to breathe. Accessory muscle usage, barrel chest, especially in our COPD patients, nasal flaring, altered mental status, and pursed lip breathing. The reason that they're using pursed lip breathing is they're trying to compensate to be able to get a breath in. Unwilling to lie down. So one of the worst things you can do for these patients that are having difficulty breathing is to lay them down. So one of the things I always encourage with any patient who is experiencing dyspnea, shortness of breath, is to always sit them up, sit those patients up, get them nice and high. We should have them in that full Fowler's position, up at a 90 degree. Bronchodilator. So what a bronchodilator is, let's think about that word there. Broncho, okay, which is going to be in the bronchioles, and dilator, which means to open up. It opens up the bronchioles. So the definition here is a drug that through various mechanisms, it relaxes the smooth muscle of the bronchi and bronchioles. It reverses bronchoconstriction. This medication actually reverses some of the bad things that are going on there. So bronchodilator is pretty good medicine. So let's take a look at some of our bronchodilators. Our medication names are going to be albuterol, metoprolol, all right? Some of our trade names there are Proventil and Ventolin, which are going to be some of the big ones that we're going to see out there. So the indication, this is the reason that we give these medications. The patient exhibits signs and symptoms of breathing difficulty due to bronchial constriction. It means this patient is having difficulty breathing. They're not able to breathe like they normally should be able to. The patient is able to use a nebulizer. So if that patient is awake enough to be able to use a nebulizer, we should give them a neb treatment. Medical control has authorized the EMT basic the use of nebulized medication. Now, here in North Dakota, every service has their very own, either their med control or they follow the state's protocol. Whatever your local protocol is for administering nebulized medications, please follow your local protocol. You can also have standing orders or verbal orders that are present. All right, make sure you're following your local protocol, your local guidelines. So albuterol, Proventil, and Ventolin. These are a sympathomimetic. The action is a beta-2 selective bronchodilator. Remember, it opens everything up. So contraindicated is to be used in caution in cardiac patients and patients with tachycardia. So precautions, let's make sure that we have an EKG on the patient, that we also have a way to monitor their blood pressure and pulse. So some side effects, it does cause palpitations, anxiety, dizziness, tremors, sweating, and sometimes a headache. The dosage is 2.5 milligrams and 2 to 3 milliliters of normal saline over 15 to 20 minutes nebulized. All right, this is a nebulized treatment. We're going to show you how to do that in just a second. So isotherine or bronchosil is also a sympathomimetic. It is a beta-2 selective bronchodilator. It is indicated for dyspnea due to bronchospasm. Please use caution in cardiac patients and patients with tachycardia. So precautions, make sure we have our EKG done. We're monitoring the pulse and blood pressure. Side effects are going to be very similar. Palpitations, anxiety, dizziness, tremors, sweating, and headache. And the dose for these are going to be 0.2 to 0.5 and 4 milliliters of normal saline over 15 minutes nebulized. Metaproterenol or ibuprofen, it is also a sympathomimetic, and it is a beta-2 selective bronchodilator. So the indications for this medication, again, is going to be dyspnea due to bronchial spasm. Contraindications include tachycardia and significant cardiac history. So some precautions here is making sure that we do have our EKG, we are monitoring blood pressure and pulse. Side effects, very similar to the other medications, includes palpitations, anxiety, dizziness, tremors, sweating, and also a headache can be common. So the dosage here is 0.05 to 0.3 and 4 milliliters of normal saline. Again, this should be given over about 15 minutes via nebulizer. So let's talk about the administration of these medications. So as you've probably heard me talk as I'm going through this, it's talking about that these medications are given via nebulizer. And so let's talk about how to give a nebulized treatment. So assure the patient can use the nebulizer. All right, they should be able to hold if we have the mouthpiece, they should be able to hold it up and to be able to take those breaths in necessary. And we sure assure that medical control has authorized use. Only do these procedures if you have been authorized by your medical control director. It's per your protocol or whatever. Make sure that it's okay at your local service to use these medications. Let's take a look at our medication. Let's make sure that it's within the expiration date. The color and clarity of the medication, it should look, if we're looking at the little ampullary, it should make sure that it's clear, okay? Focused history, so let's make sure that does this patient have any allergies to medications? If so, if they are allergic to one of the medications we're given, we don't give it. Do they have a history of cardiac problems or high blood pressure? So our focused assessment should include breath sounds. So the reason we want to give breath sounds, we just don't give anybody and everybody a nebulizer, is we want to see that there is indication for the need for this medication. And so if the patient's having trouble breathing, and we're listening and we're hearing some breath sounds that don't sound normal, we want to make sure that we document because this is an indication for the use of this medication. All right, let's get a pulse rate and quality. Respiratory rate and quality. How are they breathing? What does this patient look like? Are they using accessory muscles? Do they have pursed lip breathing? All those things are very important. All right, pulse oximetry reading. EKG, if available. Here in North Dakota, we should be getting an EKG on all of these patients, and preferably a 12-lead EKG, and go ahead and transmitting that if we have transmission capability to the hospital. All right, so this is the nebulizer. Now this is the one that a patient is a handheld nebulizer. So open and put together the nebulizer. All right, you're going to have several pieces. You're going to have a mouthpiece. You're going to have a T-piece that connects the mouthpiece up to the nebulizer. And there's typically going to be a little extender piece that comes out. All right, so use a septic technique. Let's make sure that we're using our gloves. We're being very clean. Mix the drug with a specified amount of saline in the nebulizer. Now, some of these medications are pre-mixed, but most are going to require you to put a little bit of saline into the nebulizer as well. Attach the nebulizer to the T-piece. Attach the mouthpiece, and you're going to attach the unit to oxygen at 4 to 6 liters per minute. Typically around the 6-liter mark or more, because that's what it's going to take to actually begin to aerosolize the medication and make it where the patient can breathe it in. All right, so make sure you have the oxygen up high enough to work. If an aerosol mask is used, so let's just say we have a mask that we're going to be using instead of just a mouthpiece, it needs to be turned up to about 10 liters now, so that thing will really start to blow and make a good aerosolization. Instruct the patient to inhale slowly and deeply. You're going, well, the patient can't breathe. Well, they're going to have to be able to breathe to get this medication down to where it needs to work, because remember, it works on the bronchial, so it has to get down nice and deep, way down to the bottom there. So instruct that patient, say, I need you to take a nice deep breath, hold each breath for about 3 to 5 seconds and let it out, nice and deep. You're going to have to help coach them, all right? Number one, they're going to be a little bit anxious, so we want to make sure that we're coaching them, helping them to breathe. It's going to reassure them, but it's also going to get them to breathe and get that medication nice down and deep where it needs to be at. Repeat as indicated by medical control. Follow, again, your local protocols, policies, and procedures. All right, folks, any questions, comments, concerns? By all means, please reach out to me. This is the didactic portion of this training. The next portion of the training is you'll come in and you'll actually get some hands-on experience mixing a nebulized medication and being able to administer it, showing you both how to do the mouthpiece nebulizer, but also the nebulized mask as well. And then there is a short exam for this as well. Once you've taken both of those, you will have passed the nebulized medication module according to the North Dakota Department of Health, and you can have that placed on your license. So again, if you have any questions, comments, concerns, please by all means email me.